Welcome to JAMA Plus AI Conversations. I'm Roy Perlis, Editor-in-Chief of JAMA Plus AI, and I'm pleased to welcome today's guest, Derek Angus, a Senior Editor at JAMA and a distinguished professor at University of Pittsburgh. Derek is the lead author of the JAMA Summit report on artificial intelligence, which summarizes and expands on some of the key topics from a summit that JAMA convened to think about where AI in health is going. We'll be getting his perspective after somehow finding a way to synthesize a tremendous breadth of strong opinions at the summit on where we're actually going. Derek, thanks for joining us.
Oh my goodness, Roy, it's great to be here.
Well, glad to have you. So you open the report by arguing that AI will disrupt every part of healthcare, but that we still lack a fit-for-purpose way to judge effectiveness. So for the practicing doc, what do you mean by effectiveness in this context? What does that mean at the bedside?
I love that you started with that. So what do we mean by effectiveness? That was one of the things that was very interesting in this meeting. So just to step back, these summits, as you know, JAMA has been trying to take these topics and get all the stakeholders in the room. And you alluded to the fact that it was a little bit like herding cats. It was really brilliant to have so many voices in the room. We had voices from some of the biggest companies in this space, like Google and Apple and Microsoft, but also voices from the FDA and the federal government, the Joint Commission, a bunch of academics representing different parts of this, tons of computer scientists, and so on. And I could almost ask you this question because I thought we all thought that we knew what effectiveness was, but we don't. Effectiveness is a great word. So look, in JAMA, in the pages of JAMA, I think effectiveness in most of our minds means clinical improvement. And so ideally, you're improving patient outcomes. And if you're not improving patient outcomes, you're providing the same kind of care in a way that is clearly saving cost or convenience for patients and or for the healthcare system. So I would say effectiveness is ideally improving health outcomes or at least improving clinical operations while you're very sure that the care is just as good and not worse.
And I would have naively thought that that would be a common definition. Right. So I think prior to that meeting, and if you did turn the tables and ask me the question, I would probably give a similar definition. Why do you think at the summit, with all of those other opinions and perspectives represented, why is it more complicated than that?
Yeah, I think there's two big reasons. The first is that effectiveness could just mean that it's doing what it said it was going to do. So a piece of AI is a piece of software. So, for example, in the decades of regulation that's evolved for regulating devices, and a lot of AI comes in as software as a medical device, a lot of the burden on a device manufacturer is very appropriately to make sure that it does what it said it was going to do. So a ventilator, if it says it's going to put a breath of oxygenated air into your lungs, then there's a lot of work to be done to make sure it does that and to make sure it does it exactly as specified. And so there's quite a lot of what I would call almost like a subroutine, all of the reliability of the engineering of the product. And so a lot of people, for them, effectiveness is about, can we say that this machine does what it claims to do? And that claim is not necessarily that ultimately patient outcomes will be improved. That might be seen as, well, that depends on how the physician wants to use it. Our job was to demonstrate that the product you bought from us stands up to the claim we made about what its technical job was. So that's the first issue, is sort of just, is the burden all the way up to improving clinical outcomes, or is it simply about, did the code reliably execute the task it said it was going to do? The second issue is, when you say effectiveness, again, clinical researchers might think of effect versus association, and they might think that you have to show a causal effect on outcomes. And that sort of then means, oh, you mean like a randomized trial rather than, for example, a large observational study where an improvement in outcomes may have nothing to do with the actual intervention, but rather that the patients that got the intervention were healthier in the first place. So that sort of effect versus association. The problem there is it's not necessarily been the history in much of the field of devices necessarily to sort of hold regulatory approval to some large phase 3 RCTs. And so what ends up happening is people sort of make these claims of, well, it's good for patients, or it ought to be good. Like there's this sort of large Venturi effect, this large sort of sucking along effect of, hey, if you like peanuts, you'll love peanut butter. You know, it's almost sort of assumed that it would be good for patients. But the burden of actually proving that you have improved patient outcomes, it's not clear that that burden is met or upon whose shoulders that burden rests and so forth.
So we'll get into things like regulation later, but if there are that many different definitions and we talk about AI as if it's already percolating into medicine, what are we supposed to do, right? If we can't even agree if this stuff works. And I will say it worries me to some extent that we do think of these things as devices and lower the bar to just showing, it's not electrocuting anyone. Did you feel like at the summit you left with a clearer idea of, okay, this is the way forward, this is the consensus for effectiveness? Or do we agree to disagree?
I left with a bunch of different thoughts. So first of all, let's be really clear here. I am gaga about AI. I am not a skeptic. I really think that I almost wish I was 30 years younger. Like, it would be brilliant to be starting my career with sort of all of these tools. It's like we just got handed the keys to the fastest, most exciting car you could possibly imagine. And then you discover that there's sort of no highway system, and there's no guardrails, and none of us have actually been taught how to drive. And so we have this incredibly powerful car, but sort of no real system for how to drive it around, no real driving skills.
And yet we're driving it anyway.
Oh, Lordy,
we're all
are.
out there driving it.
Lordy, we are. So I think there's a couple of things going on. So first of all, in the medical literature, there's quite a lot of talk about fairly defined pieces of AI that look like things that we've recognized from the past. So, for example, you could have a very modern piece of AI software giving an even better version of decision support than something that might have been built from a logistic regression model in the past. And you put it into a piece of software and you say things like, hey, if I use this piece of software to alert the team that the patient might have sepsis, that's like a fairly discrete task, and you could sort of test that in a variety of different designs. It doesn't need to be an RCT. It could be some sort of before and after, or like there's a variety of different ways to make causal inference from an experimental or quasi-experimental design. And it's quite circumscribed, and they're great. Most of the literature is on that kind of thing. For example, screening for diabetic retinopathy and so forth. But what's really amazing is some of the things that are most evaluated are actually least adopted, while some of the things that are being most adopted are the least evaluated. And what I noticed at the summit is some of the things that are being adopted very rapidly are because they're solving pain points in our healthcare delivery system. And they're making their way into healthcare as per the way we've set up the system for them to enter. And so a perfect example might be the use of ambient AI to be sitting there in the room when you're having a patient encounter. And before ambient AI came along, that was becoming an increasingly horrible experience. That you thought you went to medical school because you wanted to be sitting there having a conversation with the patient, getting your stethoscope out, putting a plan together, etc. But then someone says, come on, you have to see 10 more patients, you have to do it quickly. You have to do a ton of documentation, you have to drop all of your bill, and if you can't finish it now, when you get home tonight, put the kids to bed and then finish your notes. And then someone came along and said, well, I could make your day much better. I could put this little microphone in the room, we could record it, and then, hey, presto, you'll have a little assistant who has helped put your note together. And so now you'll get through the patients in time and you'll get to the end of the day and you're done. There's no more coming back later. So that just sounds so seductive and it's great. But it turns out that if that's the instrument that you're bringing into your healthcare delivery system, well, that's sort of an administrative task. That doesn't even necessarily qualify as a medical device. It doesn't even need to go through the FDA. And that's just going to help administrative tasks. And people start using it, and we can talk about whether everyone actually likes it or not, but it feels like it's really directly tackling a horrible pain point in current healthcare delivery. And so the thing takes off like wildfire. And then we can talk later about whether it's doing only its initial circumscribed task or whether it's then capable of mission creep. But it gets very interesting.
Well, it does. And we started by talking about effectiveness. Scribes are maybe an example of, I'm not 100% sure what effectiveness looks like for scribes.
You and me both.
And I should say for our listeners that I may or may not have accused you of being an AI skeptic at one point. But I think what I meant is AI warrior, because it is, as you said, these such incredible tools, and yet someone gives you the keys to this amazing car, and it's easy to do great harm to yourself and others with this amazing car. I'm wondering how much you actually worry about that part of the equation. Does some of this stuff end in tears?
Right. So I think if we just stayed with ambient AI, no matter how many books you've read, no matter how up to date you are with up to date and all the rest of it.
Remind me what books are again?
Remember those? So no matter how on top of your game you are as a clinician, chances are you could be tired, you could encounter a problem you don't know that much about, you could miss something, etc. Imagine if when you're sitting there having a conversation with the patient, there is some all-seeing computer running in the background, keeping track of the discussion you have, and then able to interrogate some huge database. Let's say it's running some digital twin type algorithm or whatever it's running, or it's simply just combing through the literature and looking for pattern recognition and bringing the most up-to-date information available. A little bit like in having R2-D2 or one of those sort of robots on the spaceship. You wouldn't want to fly the Millennium Falcon without that robot in the corner because, things are coming at you fast. So conceptually, I can't imagine as a doctor or as a patient that properly deployed, we wouldn't be better off with some sort of ambient AI running in the background. Let's say we're taking care of consent, we're taking care of ownership, we're taking care of privacy, all of those things. Conceptually, it feels like this is absolutely a tool we would want. But how do we know that we're only harnessing it for good? So for example, let's say that the algorithm, first of all, the algorithm begins to elbow its way into the patient-doctor relationship because it starts out by sort of summarizing the note for you, but then it summarizes the note in a way that's maybe different from the way you would have summarized it. But then how much work does it become to delete what it suggested and type in your own version? And after all, eventually it says, hey, that looks like pretty good to me. And so it subtly begins to change, who's actually in control here. And then that's true when it gets not only to forming a diagnosis, but making treatment recommendations. And so it's a super valuable conceptual instrument, but it could quite quickly sort of be doing a lot more healthcare delivery than we realize. And then if you said to me, well, what's the design to evaluate its effectiveness? That's tricky. I mean, it could be running large across millions of healthcare encounters, being deployed in slightly different ways across all sorts of different disease conditions, offering all sorts of different kinds of advice up at different moments in these encounters. So, if you were saying do a trial of it, like the inclusion criteria, the patient outcomes, like this is a stretch for our methodologists to even sort of think through what the right evaluation design would look like.
Well, and it's gone from being sort of novel to being everywhere in a lot of health systems.
So fast.
I mean, I would say a year and a half ago, I'd heard the term, but that was about it. And now it's in just about every clinic at my place, and I think probably at yours as well. And it's one thing if it's purely transcribing, right? If it's purely transcribing, we can probably agree on how that works. But what you're getting at, I think, are sort of unintended consequences, or at least underappreciated consequences when it starts to sort of shape the note a little bit or tell the story a particular way. It's sort of like the first generation of papers on language models where people would feed them vignettes, from journals like JAMA and say, oh, look at that, it got the case right. And of course, it would get the diagnosis right because the case was presented in a very specific way. And, that was by design. But when the ambient scribes get better at telling the story in a certain way or decide to tell the story in a certain way, as you said, undoing that almost becomes more work for the doc rather than less.
I know. And you're surely not wanting the doc to be the surveillance instrument for the scribe. I mean, we all know how well doctors correct spelling errors in transcription. We're not built to be surveillance tools. So I don't know who is minding the store here. I sound very negative about this, but I really do mean that I think of ambient AI as a fantastically exciting opportunity. And I also think that we actually need to stimulate methods development for sort of novel, efficient evaluation designs. Like, it's hard for me to even get my head around what the trial design looks like. But I have faith that if one were to, set out RFAs for innovations in trial design, like the community at large would likely come up with lower cost, fast, efficient ways to give robust evaluations. And so I really don't want to come across like a Luddite. I think it's a brilliant opportunity. We want to embrace it, but we need an investment in stimulating our own methods development so that we can do higher quality evaluations of how these things are working to help steer them the right way.
So it's interesting the way you frame it as our evidence generation methods haven't necessarily caught up with our tools, because I do think, again, initially it was sort of case reports and vignettes, and then it was a little bit of retrospective validation. And, now we're starting to see some randomized trials. But as you point out, for stuff like scribes, not clear that that's the way to do it. I'm also, look, I'm a shrink. So we have to go after why do we both sound so worried if we're both so enthusiastic about this technology?
Is there a name for that?
What I was going to say is, one of the things you do in the paper that I like a lot is you do break down AI, not necessarily in the more sort of traditional way that people are accustomed to thinking of it, but you kind of go after, these are clinical applications, these are direct to consumer applications, these are sort of business operations. And then you sort of acknowledge that there are probably these hybrids, and, ambient may be one of those, right? Because it's sort of clinical, sort of business operations, may even end up a little bit direct to consumer if some of these notes are going straight to patients or patients are writing directly into the chart. So why break it down? What motivated your decision to break it down in that way and frame the discussion that way?
Yeah, so it was interesting. So the first thing I thought about was the things you read about in JAMA or Nature Digital Medicine, etc., are all these traditional clinical tools that are going to help a provider take care of patients, like a diabetic retinopathy screener, improving the life of radiologists, or maybe improving the life of radiologists. And so those were the clinical tools. And then, of course, there's the rise of these tools that are direct to consumer. They could still be very much medical devices, things like screening for AF through your smartwatch, or it could be a chatbot for sort of mental health. And there's all sorts of issues about that. But that's absolutely about some tool that might be in your iPhone where there may or may not even be a healthcare provider involved, which could be very disruptive in a very positive way, although scary for healthcare delivery. So those two categories existed. And then I was thinking of the third category, which, as best as I can tell, was the category that healthcare CEOs are actually buying all that software that's sort of optimizing OR scheduling and staff scheduling, et cetera. And that was all sort of these business tools. And it's just the healthcare version of the same tools that you see advertised by SAP and all these other companies when you're walking through the airport, revolutionizing business processes, finance management, et cetera. But then I realized that, and it was partly when I thought there were only three kinds of tools, and when we were doing drafts of the paper, and people were disagreeing about whether some of the tools were business tools or not. And they come in as if they're sort of helping business operations, but they are actually going to affect clinical care at the same time, like ambient AI, or even things like OR scheduling, etc., or helping a patient navigator get to the right patient. And indeed, if you go onto the websites of some of the companies that offer these business management tools, they often have testimonials from like chief quality officers or chief nursing officers who sit there and say, this tool is helping our patients have better outcomes. I mean, the tool is, they're making an explicit claim that it's improving the clinical performance of their organization, in which case that sounds like a clinical tool, but it's being sold as a business tool. And that's where I mean, they're hybrid tools. They're tools that are meant to maybe improve operations and in so doing, improve clinical outcomes. And they sort of blur the lines. And if they're sold as a business tool, it's not clear that they ever show up on the radar of an organization like the FDA. And yet they're being sold with this sort of claim that patient outcomes will be improved. And then you think, wait a minute, if patient outcomes are being improved, isn't that a clinical device? Don't you need to call the FDA for that? And that's what I mean by this sort of hybrid world.
So does that kind of work belong in JAMA? Does the business side of things, this makes the hospital more efficient? Is that JAMA? Or is that, I don't know, Harvard Business Review or...
Yeah.
And I mean, I'm only sort of kidding about that because there are these tools that may make the hospital run better. I mean, I guess it is clear who the purchaser is, but should the average doc sitting and reading JAMA care?
So the average practicing clinician at the bedside may feel, I'm not sure how this helps me in my day-to-day practice, but I would say that the entire field of health service research has been worrying about these kinds of interventions for decades. That AI, when it's providing these tools, is AI in front of a tool that I would say we've always cared about. So, for example, JAMA or similar journals will take papers on, hey, if you have chest pain, should you be seen by a cardiologist or by a generalist? Should you have a regionalized healthcare delivery system? Should you have an anesthesiologist staffing an outpatient gastroenterology procedure, or can the gastroenterologist do it on their own? There's an almost endless list of health services delivery and organization questions that, to be quite honest, we have never made a decision on whether all of these things should be exposed with the same rigor as we test a drug. And yet health services researchers have made the point for decades that some of these interventions have as big, if not a bigger effect on patient outcomes than giving a new drug or not. These systems can have, the way you organize and deliver care can have huge effects on access and so on. They're not drugs, but they're potentially hugely impactful on patient outcomes. But that said, it's in part because we have never got our heads around whether these interventions deserve to be studied in the same way, that then when these AI tools come along, someone would say, well, why should AI have to be judged this way when we never judged these things in the past? To which I would say, fair point, although those other things have gradually crept in over decades, whereas we're now about, you could think of these AI tools as like the biggest bolus of massively disruptive health services and delivery interventions as we've maybe ever seen. And while it's absolutely true that we've always done a bad job of consistently evaluating them in the past, that the rate of change in delivery could be so accelerated through AI that maybe we should get our act together and demand a much more considered evaluation of these kinds of interventions.
Well, this is what I'm thinking about as you're talking, is that the purchaser of these tools is probably not asking for a randomized trial or a cluster step wedge, or any of the, they're asking, is this going to save me money? They might be asking for some sort of cost effectiveness, but not the kind of cost effectiveness we're used to. So again, it boils down, again, it's about effectiveness, right? What's the effectiveness measure that the decision maker for this stuff is asking for?
Well, 100%. The purchaser is some faceless healthcare CEO or some purchasing organization on behalf of the CEO. They're not held accountable for improving care. They're hoping that they hire doctors who are high quality doctors, etc. They may well rent space on the sides of billboards that claim that they're a better hospital than the place down the road. But they're not going to get less money from Medicare simply because they couldn't demonstrate that they accelerated the pace of learning, that they got to newer and better treatments faster. That's sort of all on the shoulders of the people responsible for innovation in healthcare, whether it's pharma companies or people getting NIH grants, etc. That's now merging into the topic we discussed in the first summit about sort of the tendency for like a little bit of a disconnect between the clinical research world and the clinical care world. And the only way you would probably close this gap is if you did actually hold clinical care delivery organizations responsible for demonstration of improved outcomes over time. That some part of their reimbursement, I'm not saying that they would get less reimbursement, but they might be eligible for more reimbursement if they could show that they were solving problems in their neighborhood, sort of accelerating the health of their community. That's tricky, but it would help align the incentives, and then it would certainly make these healthcare systems view the purchase of these, for example, these new AI devices through a very different prism.
So I want to ask you one last question, and you can riff off the paper or you can just kind of go with your gut here. But since we've already established we are both enthusiasts, what's the thing that you're most excited about when you think about like, wow, this stuff is really cool? If you look ahead to the next couple of years, what's the example that you hold up about why you're an enthusiast?
Yeah. So it involves both a little bit of AI and a little bit of data infrastructure. But I would like us to really get to fully deployed, and this is going to sound a bit geeky, sort of live edge decision support. I would like to get to the point where when a doctor and a patient are in the room, there's never a missed opportunity. And by that, what I mean is that as that doctor is encountering the patient, they are able to command at their fingertips a distilled understanding of all the literature to bear on that moment. And so if there is a clear winner for what to do next, to sort of say, given what you tell me, overwhelmingly, the thing that you should try to take next, the drug we should give, or the behavioral intervention we should try, or whatever. The overwhelming evidence suggests X. Hey, then that's great. And then you could be reassured that whenever there was a clear, obvious choice, that the doctor and the patient both knew about it. And there was never an opportunity for decisional regret afterwards about how someone didn't know enough. No knowledge wasn't available in the room. That's part A of live decision support. Part B is if it turns out that when all of the literature is amassed, the doctor and the patient look at this moment and say, oh, it's not actually clear. Of all the things we might do, there's actually 2 or 3 good choices and we're not quite sure. Then it would be nice for the doctor and the patient with awareness to then enter at that very moment into some sort of evaluation, whether it's an embedded randomization or an embedded randomized prompt about what one might want to do. Again, I don't want to get into what the trial design would be, but some sort of knowledge generating instrument. So if there's no uncertainty, make sure that everyone knows what's already known. And if there is uncertainty, have the instrument facilitate the moment for the patient and the doctor to then be part of a new study that's going to get to the answer. That's my sort of big vision. It's a little bit like the big green button that Nigam Shah and others sort of talked about a few years ago. And it's got a lot of work to be done just with logistics, with the EHR. And it involves sort of pretty sophisticated AI in the background.
For once, I find I can't actually think of anything cynical to say about that. That would be fantastic.
Well, you asked for the Holy Grail. I
think for all the noise about learning health systems, that would actually be a health system that learns as it goes.
Absolutely.
Right?
Absolutely.
And their AI would be facilitating that learning.
Exactly.
So, Derek, thank you so much for talking to us about all of the above, all of the complexities of real-world AI deployment. To our listeners, if you want to read more about this particular paper and the summit, you can find the link to the article in the episode description. And if you want to read even more AI, check out JAMA Plus AI at jamaa.org. To follow this and other JAMA Network podcasts, visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for joining us, and we'll see you next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.